Hi, everyone. Thank you so much for joining today. We're going to go ahead and get started. I think we'll have a few more people jump on, but I know everyone's busy, so we will dive right in. Again, thank you for joining. My name is Margaret Rogers. I'm the Director of Marketing at Natalist, and I've been on the Natalist team for 5 years now. I'm a founding employee, and I am very, very passionate about the work we do at Natalist. I'm a mom of 3. I went through secondary infertility, and I have 2 babies via IVF. So again, just very passionate about what we do at Natalist and really excited to chat with Dr. Gleaton today. I would like to introduce Dr. Gleaton, my colleague and friend. Dr. Gleaton is a board certified OBGYN, and she's also the medical advisor of Natalist. She received her medical degree from the Medical University of South Carolina, and she completed her residency at the Carolinas Medical Center in Charlotte, North Carolina. Dr. Gleaton is passionate about women, health equity, and mentoring. In addition to working with Natalist, she's also the founder and CEO of her medical practice, the Epicenter, an OBGYN spa-like practice. And she's also a clinical faculty member of Charleston Southern University. She's a member of the American College of Obstetrics and Gynecology, the American Association of Gynecologic Laparoscopics, and the American Association of Professional Women. Dr. Gleaton, in addition to all of that, is also a wife to her husband, also a Dr. Gleaton, and her 2 young sons. So thank you, Dr. Gleaton, for being here today.
Thank you for having me, Margaret.
All right, let's dive right in. Thank you, everyone who submitted questions in advance. We're really excited to cover these questions. It's so important. So let's go right into it. Okay, question number 1. I was just diagnosed with unexplained infertility and I'm feeling lost. Any best next steps you'd recommend?
Absolutely. I first just want to say thank you guys for having me on. I'm so excited. And, as a former infertility patient, I really get excited and just overjoyed by talking about this because I feel like there's so much guilt and shame associated with infertility. I remember just feeling isolated when I was going through and almost just embarrassed because I was an OBGYN delivering everybody else's baby. And I feel like I couldn't make that happen for my own family. So first, thank you guys for honoring me and having me here. And I think that's a great segue into this first question because, again, when you get the diagnosis of unexplained infertility, just like I did, you kind of feel that it's almost worse than having a diagnosis. You kind of want some answers. You want something that you can fix. And for this diagnosis, you really don't get that satisfaction. And so I feel like I felt very lost. And I think I remember just kind of feeling overwhelmed in that moment. And I remembered something that my grandmother had on her wall. This might age me a little bit too, but you guys might remember it was a serenity poem where it just basically talked about asking God, like, to grant us the grace, to accept the things we can't change. And that's kind of how I felt with this diagnosis, but also the courage to change the things that we could and the wisdom to know the difference. And for me, I decided instead of focusing on the things I couldn't change, like that diagnosis, I would just focus on the things that I could change. And so I decided to focus on like my mental health, making sure that I was reducing my stress and taking care of myself from a self-care standpoint. I focused on my diet, making sure that I was making healthy choices. Going through medical school and residency, we kind of live off sugar. And so I really had to wean myself off of processed foods, increase my exercise, and that was also mental health as well as physical health. And just do the things that I knew that I could control. And that gave me some satisfaction in knowing like, hey, I can't change that diagnosis, but I am going to go forward and make sure that I'm the healthiest person so that when I do conceive, because as you know, many patients with unexplained infertility will conceive. It might not be in the timing that ACOG says you should, but often you will conceive and you want to be the healthiest version of yourself when you do. So I focused on those other things.
So important. And I know myself from going through it, I found support and community and just hearing other people's experiences. So thank you for sharing that, Dr. Gleaton.
Yeah.
Next, can you explain a typical beta HCG progression you'd like to see after a transfer?
Yeah, I get this question a lot in the office, just with regular pregnancies as well as like after IUI or transfer. And it can be confusing because the range of HCG levels, they overlap. And so there's not like an absolute range. However, we do know that anytime you have a positive pregnancy test, your beta HCG hormone level should be greater than 5. And then we expect those levels to increase by at least 50%. Some studies show 40%, but 40 to 50% or doubling every 2 days. And some studies say 2 to 3 days. And so we know that when you have gotten like a positive pregnancy test at that initial outset, that pregnancy hormone level is probably about 50 to 100. And then by 2 weeks after, it should be like 1,000 to 5,000. But like I said, there's a huge range. So as long as you're following the doubling or the increase by at least 40% every 48 hours, you're probably in a good range.
Yeah, absolutely. And we have some great content on our blog that explains this a little bit further. I know when you're going through it, it's like so much information to take in. So feel free to reference our blog and always, ask your REI, ask your doctor any questions that come up in your mind. Next question, any harm in using a menstrual cup after sex to assist in getting pregnant?
So, Margaret, I'm going to give my own answer to this because I can tell you that I don't know of any studies that suggest whether it's beneficial or not. But in my mind, the way I think of things and just physical anatomy, I don't think there's any harm in placing a menstrual cup after intercourse. I just would recommend that you remove it usually within like 1 to 2 hours because that's going to give you the most benefit of making sure that the sperm are close to that cervical mucus and going into the sperm, especially, I'm sorry, going into the uterus and hopefully making it to the tubes, especially if you have a tendency to notice that after intercourse, you have a lot of vaginal drainage and thinking that maybe the sperm didn't make it where it should.
Very helpful. How long should we try IUI before transitioning to IVF? So I'm sure Dr. Gleaton will share this, but there's a number of treatments and procedures you can explore if you're going through infertility. And so these are two of them.
Yeah, and so many times patients have already tried what we call oral ovulation induction, where you're just taking pills for about 6 months with your OBGYN. Often that's a first step, but not correct for everyone. And so after that, usually you go to IUI or intrauterine insemination. And there are various factors that determine when you should transition to IVF. And often we look at a patient's age. And so if your age is over 35, we are likely to recommend that you transition to IVF a little sooner. And most studies would probably suggest trying IUI for about 3 cycles. And then if you haven't been successful, then I think that's the right time to go on to IVF. If you are under 35, then you can do IUI for up to 6 cycles. And when you're an infertility patient, every month seems like a year. I will tell you, every time you see that period, you're just kind of like devastated and crushed. And so, I will say that most patients will transition to IVF before 6 cycles, but it's no harm in doing 6 cycles. And sometimes you can definitely get pregnant on some of those latter cycles as well.
And everyone's journey is unique. Some people, depending on your specific and unique circumstance, you may go straight to IVF. I know myself, my husband and I, we went straight to IVF because of our history, and it was just the right answer for us. But everyone's experience is different. And just because Dr. Gleaton says something today, your journey may look different.
I'm glad you brought that up, Margaret, because you're right. Like there can be other factors like tubal factors or sperm factors or male related factors that affect fertility. And so you want to make sure that you have like a good reproductive endocrinologist that's helping you to look and evaluate all the data to come up with the best treatment regimen for you.
Absolutely. Secondary infertility here. Why am I struggling so much with a second when my first was an accident? I went through secondary infertility myself, did not use fertility procedures or medications with my first child, and then 2 via IVF. So this is near and dear to my heart.
Absolutely, Margaret. And you're not alone. I didn't realize this, but up to like 50% of infertility patients represent secondary infertility. And it's always a shock because many times when we're trying to conceive, we get pregnant right away. Often we're just coming off of birth control pills and we know, or some form of birth control in general. And we know that first month after stopping birth control can be the highest opportunity to get pregnant. So many of us get pregnant right away. And so we have no idea that when we go to grow our families, that we will have difficulty conceiving the second time around. And so this is pretty common. So I first want you to know that you're not alone because up to 50% of cases are this way. But two, there are some things that explain why you might be struggling. So often it's just kind of spacing in general. So often when we conceive with our first child, our age is a little younger. And if you already have a toddler or infant or even a 5-year-old or a 9-year-old like mine, you're stressed, like you're a mom and you have a higher level of stress often, which can also affect like your ability to conceive. Often we maintain or hold on to a little bit of weight after pregnancy and becoming a mom. I find myself digging into Cheez-Its, whereas before I had one child, I would never eat Cheez-Its. So sometimes our dietary factors, our lifestyle factors are different. Often we are in a higher level of job opportunities. So our stressors from our jobs are a little greater too once we're trying to conceive that second time around. So there are just lifestyle factors in general that explain it. But also we know that physically, like the egg age can affect whether we conceive. And then also there are male factors, like, so certainly sometimes we develop bad habits like excessive alcohol or smoking or excessive caffeine that can affect male and female fertility. So I think it's just a combination of factors that lead to secondary infertility.
Yeah, it's very complex, and you may also just never know the answer, which is not the answer you want to hear. But look forward, ask your doctor any questions that come up. What are the best tips during IVF to get successful implantation/pregnancy?
So I think it starts from the beginning of the journey, right? So by the time you're doing IVF, and this sounds a little different from Margaret, your scenario, but often by the time you're doing IVF, you've already tried a lot of things. You've already possibly, depending upon your age, waited 6 months to a year and just tried natural conception. And then often you may have tried some oral ovulation induction agents with your OBGYN. And so when you get to IVF, or even you may have tried IUI, but by the time you get to IVF, you want to make sure that you've done your research. I think your homework is super important. You want to make sure that you're looking at the ASRM, which is the American Society of Reproductive Medicine's website, to make sure that your RAI clinic is an accredited clinic, making sure that they have good outcomes, they have high success rates. And I know that there's a lot of frustration regarding that as well, because data can be manipulated based on what kind of complexity of patients that you accept and how often you do these and all various factors. But at the end of the day, most success rates have to be published, and you can see those success rates, and making sure that you also within the clinic, making sure first that they're accredited and they have good success rates, that you find a reproductive endocrinologist that you can really identify with, one where you feel heard, and that you feel like you have a good rapport or relationship with. I think that's important as well. Beyond that, I think just the factors that kind of help conceive naturally also is paramount. So you want to make sure that you're reducing your stress, you're staying hydrated, you're watching your lifestyle factors, you're following the regimen that your RAI has set forth. I can't tell you how many times patients get overwhelmed because it is a lot. Like you're getting blood draws and ultrasounds and you're taking these hormones and shots and all these things. It can really be demanding on the body, and it's easy just to kind of maybe miss some information or opportunity. So making sure that you really have clarity on what you're supposed to do, how often you're supposed to follow up, because those things can also affect your success rate.
Absolutely. I know myself, I was so eager to get in with the fertility clinic. So I took the consultation with the first doctor that had availability. We met with him, and I just didn't feel comfortable after I left. And in my head, I was like, should I ask to switch? Should I go to another doctor? And the initial doctor, he was fabulous, so intelligent. It just I didn't feel like my most comfortable self. And so I called and requested to switch to a female practitioner. And I didn't have to give any explanation, but switched to the female practitioner. And I was just so much more comfortable. I felt comfortable asking any questions that came up in my mind. And so that just, I felt more supported going through the process. So speak up for yourself, advocate for yourself. Another tip just that I personally found, and I know everyone's work scenario is different, but if there is a colleague or manager that you feel comfortable sharing your experience with, I found it was very helpful to share my experience with my manager at the time, just so they would know that I would have to frequently go to doctor's appointments. And so that was just one less thing I had to stress about. I didn't have to worry about missing work or coming up with excuses. Again, everyone's experience is different, but if you do have that open line of communication with your manager or someone on your team, and you feel comfortable sharing it with them, I think that could be potentially one less stress factor in your life when you're going through it.
Yeah, Margaret, you're exactly right. And I sometimes recommend that patients ask or request from me or from their REI intermittent FMLA, because all jobs are not created equal and all managers are not created equal. And I know some of my patients are in male dominated fields, and they really kind of feel not embarrassed, but just a lack of, well, they want to protect their privacy, and there's nothing wrong with that either. And so intermittent FMLA does not have to be, the reasoning or rationale does not have to be revealed to your employer, but it does protect your job and allows you to have the flexibility to leave for those ultrasounds and those shots and those appointments with your doctor, because they can be pretty intense.
That's such an excellent tip to know. So if you're going through this, definitely ask your REI or OBGYN about getting the forms filled out for intermittent FMLA approval. Infertility/multiple miscarriages caused by endometriosis. Do you have recommendations for moving forward?
Yeah, endometriosis. Yeah, if you talk to any OBGYN, it's a very frustrating illness from the standpoint of us feeling very limited in our ability often to correct the problem, right? Because when you think about it, I often tell my patients who are diagnosed with with endometriosis, there are two goals when you have endometriosis. You are either trying to get pregnant or you are trying to stop your periods. There's not a lot of in between. And so when it comes to trying to get pregnant, then often the endometriosis can become progressive during those months. So we usually encourage pretty aggressive trying to conceive tactics, I should say, by using ovulation predictor tests and things of that nature, because you do want to make sure that you're protecting your female reproductive organs, but also, trying to conceive and achieving those reproductive goals. So at the end of the day, I usually ask that you kind of course, meet with your OBGYN or your REI doctor and just set out a timeline. Say, hey, gosh, you know what? I know I have endometriosis. Maybe instead of, if I'm under 35, maybe instead of giving it a full year, I might just give it 6 months, because I might say, gosh, after 6 months, maybe I should do something to maybe enhance my options for getting pregnant every month, or my ability to, by considering like some ovulation induction agents. And I think a lot of endometriosis patients feel comfortable with that, being a little more aggressive, because we do know that endometriosis and natural cycles can progress that. And so at the end of the day, I think just kind of coming up with a good game plan with your REI or your OBGYN, and making sure that you understand that, hey, you know what, I might need a faster time frame. But also when you have endometriosis, those periods can be really painful, and every month can, again, feel like a whole year. And so just making sure that you just know what the options are. And if you need to, and if you feel comfortable going straight to going straight to your REI doctor and getting some advanced reproductive technology, there is nothing wrong with that. And don't let anyone judge you based on that. Yeah.
Absolutely. What do you think is the best way to track my ovulation?
I think the best way is the one that you stick with and that you continue to do. And that answer is different for everybody. So we know that there are lots of ways to track ovulation. There's basal body temperature, which for me never worked. I was never going to check my temperature at the same time every day. But some folks are very diligent and they're able to keep up with such a pattern. Of course, there are ovulation predictor kits. They're usually pretty easy too. But again, that might not be right for everybody. So there are also wearable devices devices that can kind of help manage, or I guess monitor, your heart rate and your skin temperature and your basal body temperature to give you a better idea. There's cervical mucus checking as well. So there are lots of options, but I think the best one is the one that you can stick to, and the one that doesn't cause so much stress and anxiety, which they all can, if you ask me.
Yes. How common are hormonal imbalances? Can they cause chemical pregnancy or miscarriage? And maybe before you dive in, even just explain the difference between a chemical pregnancy and a miscarriage.
Yeah, so a chemical pregnancy is a pregnancy that usually ends before 5 weeks. So usually you have a positive pregnancy test, you get really excited, and then before you even reach that 5th week of pregnancy, you start having spotting and a period per se. And a lot of folks who are not trying to get pregnant don't even realize they're pregnant. They just think they had a late cycle, like, oh goodness, my cycle was delayed by a week. Because often at such an early gestation, you're not going to have the symptoms of nausea, vomiting, breast tenderness, and those clues that might let you know you're pregnant. Whereas a miscarriage usually happens, of course, after that. And often patients don't know the difference in the nomenclature, and that's not a big deal. But usually, when we're looking at miscarriages or chemical pregnancies, we do think about, as one of the first options that could contribute to it, is hormonal imbalance. And so you could have various hormones that are out of whack. You could have polycystic ovarian syndrome, where we know your testosterone levels are high, and that can lead to some insulin resistance, and that can lead to a higher risk of miscarriage. You could have thyroid abnormalities. Even if it's too high or too low, you could certainly have recurrent miscarriages or difficulty getting pregnant. You could have a progesterone deficiency, and that's a hormone that's imperative for maintaining a pregnancy. And so if you feel like you might be subject to or experiencing some hormonal imbalance, it's pretty easy to check these hormones. These hormones have been around forever, so they're not like new expensive testing. It's pretty straightforward in getting a recurrent miscarriage panel. And one thing I feel like everybody knows about progesterone and thyroid, but one thing that's often missed or left out is something called antiphospholipid antibody syndrome. And that usually should be, that lab panel should be drawn if you have had more than 2 miscarriages. And so if your OBGYN doesn't bring it up, please bring it up, because and this one is kind of rewarding to test for, because if you come back with that positive diagnosis, there's actually something we can do about it, right? So we can kind of put you on some medications to help prevent a recurrent miscarriage. So definitely, I think just kind of devising a plan, starting by checking your hormones, and then correcting whatever the imbalance is.
So a recurrent miscarriage panel, if people are interested, that's what they should ask their OBGYN about.
Absolutely.
Great, thank you. What is the best diet for someone trying to conceive? I know you mentioned a few times earlier on in your own experience how you tried to adjust your diet. So if for someone who's trying to conceive, what is the best diet for them?
Yeah, so I like to start, when we're talking about diet, I like to start by letting folks know it's not all or none, right? So I know for me, I might not be like everybody else, but for me, I'll do really good for about 3 or 4 days, and then I just crash, and I have to have some Cheez-Its or something sweet, and the whole day I'm just off, and then I kind of get back on. And so if that's the case, it's okay, like 80-20, right? So give it the 80-20 rule, and just make sure that 80% of the time you're trying to honor a diet that helps your body function the best and reduces inflammation. So that's usually going to be like a Mediterranean style diet, where you have less processed foods, less saturated fat, less simple sugars. You're going to replace those things with complex carbohydrates, less sugar, natural foods, including like fruits and vegetables, very lean meats, increasing legumes, because you want to make sure that your body has everything it needs for your eggs and your ovaries to function at their highest capacity. And this is not just for females. I think I got an email recently talking about the fact that it's like male infertility week or month or whatever. And we kind of put something out about that, because it's not just your eggs and your ovaries, all right? So we want to make sure that the sperm and the sperm quality are such to where they also are, they have good mobility and motility and the adequate number. So I think this is a journey that both participants who are trying to conceive should make sure that they're watching their diet, to make sure that they have the necessary things. And then lastly, I would just say that you need to make sure you have a good prenatal vitamin. I know all the time folks tell me like, I don't take a prenatal vitamin, it's not that important. And it really is. It has like a lot of micronutrients that are necessary to make sure that you are not only trying to conceive, when you're trying to conceive, that you have all the necessary resources, but also when you're actually growing a microhuman, a little human, you also need those micronutrients. And so I would definitely give a little shout out to our prenatal gummies. I would put them up against anyone on the market in terms of the comprehensiveness of the ingredients. And so just making sure that you have a prenatal vitamin that's going to not just give you the basics required by the FDA, but might have some of the things like folate and choline and some of the things that might not be in some of the traditional prenatal vitamins. It's definitely worth it.
Yes. And if you are really looking to dive into diet and the best nutrients to support you, we sell a great book on our website by a research neuroscientist, Dr. Nicola Vina, called What to Eat When You Want to Get Pregnant. She has written a few books, and this is a really great one that's specifically geared towards people that are trying to conceive. Another endometriosis question. I have endometriosis. Should I be concerned if I have not had any luck conceiving after trying for 8 months?
I don't know that I would say you should be concerned, but I think I would just recommend, I'm all about patient advocacy, and I would recommend that you become your own advocate and meet with your OBGYN or your REI and establish like a timeline and a plan. And I think sometimes that's comforting, just knowing like by XYZ, if this hasn't happened, then this is my next step, as opposed to just kind of feeling like you're eternally trying and you don't have a game plan, right? And so I would just recommend just kind of establishing a plan. The other thing I would say is that this is highly dependent on other factors. Like many of us don't know that there are different stages of endometriosis, and the stage can be sometimes associated with that infertility diagnosis. And so making sure that you know like what stage you have, if you and what treatment options there are, and whether if you're over 35 versus under 35. So there are a lot of factors that play into how endometriosis can affect your ultimate fertility options.
Should I be testing for ovulation every single day of my cycle if trying to conceive, or just during my potential fertile window?
Well, I think it just depends on on how type A you are. Not just kidding, but it just depends. But usually we say, because I think that can really become expensive and tiring, to be honest. But to each his own. But I would typically recommend that you start trying, or you start your ovulation predictor kits a couple of days before you think or you're supposed to ovulate. So sometimes folks choose to start between days 6 and 8, and then sometimes folks are like days 8 to 10. But as long as you're starting like a couple of days before ovulation and you're capturing ovulation in those cycles, then you're probably good. Now, if you're having issues capturing ovulation, then that's a different scenario, and you might need to do a month where you're kind of trying to figure out exactly when you have your LH surge.
Yes, absolutely. And I know in our ovulation test and our instructions, we have specific guidance on if you're unsure of when you ovulate, we have a recommended cycle day that you should start testing just so you capture that window, like you said, or
Right.
increase the likelihood that you'll capture it. Next question, and a food question. Do you think the food we eat plays a role in hormonal balances?
Absolutely. What we ate is much different than what our great grandparents would eat. And, we no longer live off the land per se. So there's so many things, impurities in our foods that can interrupt. They're like endocrine disruptors. There's so many things. And even, I've been surprised because even things that I think are healthy, and a lot of even like vegetarians, sometimes they're eating more soy products. And I didn't know this, but soy can also interrupt like certain aspects of your metabolism as well as absorption. And so you have to be careful that you are reading what you're eating, but also knowing like how various ingredients can affect your health. Because the phytoestrogens, I just didn't put that together that could affect like fertility and things like that. But of course, like having consuming too much protein, consuming too many processed foods, those all can affect our insulin resistance and our ability and our hormones ability to regulate and maintain our metabolism. So definitely, I bet in that book, Margaret, that you mentioned, there's probably some explanations in terms of how the foods can interfere with our hormone and our balance.
Yeah, it's really fascinating how much what we consume affects our body and our well-being.
Right.
Next question. Should ovulation test have a faint line all cycle long? Can this ever be an indication of pregnancy?
So I think that's a little tricky because I would think that if your ovulation tests have like a faint line all cycle long, then you're not really capturing ovulation. So I would talk to your OBGYN or your REI doctor about maybe seeing if you could get a blood test to see to better pinpoint when you ovulated. And of course, this is kind of frustrating too because you kind of get the progesterone level checked after your supposed ovulation. But if you get a positive ovulation like 7 days, 7 to 10 days after, then you know, or a positive progesterone level that supports ovulation, then at least you know you ovulated. But there are a couple of conditions like hormone imbalances, like we've talked about, that can contribute to like having a faint line and looking like your LH is always positive. One of the main ones that we always reference is polycystic ovarian syndrome. So I would maybe just ask your OBGYN if you can get like a reproductive panel that would include your testosterone and your progesterone and your estrogen levels, and just kind of seeing if there's some kind of imbalance that would explain why you're not capturing ovulation.
Yeah, and I'm noticing a theme here. Speak up and ask questions. And I think one helpful thing before you're going into doctor's appointments is to write down all the questions you want to cover, because sometimes when you get in there, you just forget to ask something that's been on your mind. So definitely take advantage of a list and bring it with you, as well as if your doctor has a portal and you can message. I've found that very helpful as well.
Absolutely.
All right. Is it unusual to have my only 2 positive ovulation tests on cycle day 14, but no egg white cervical mucus until cycle day 16 or 17?
Yeah, this suggests that you might just be ovulating a little later, like a day or two later. And there's nothing wrong with that as long as you're getting consistent positive ovulation predictor kits. And we do know that usually the LH surge is what foreshadows or forecasts the fact that you're going to ovulate. So that LH surge usually happens about 12 to 24 hours before you actually ovulate. But that cervical mucus can show up usually around the time of ovulation. So that does not concern me. It makes a lot of sense to me that you're going to get that LH surge first, which gives you a positive ovulation predictor kit. And then afterwards or subsequently, you'll see the cervical mucus.
Great. Best place to start with male factor infertility. We didn't figure out until 6 months of exclusively testing me.
Yeah, you're not alone. I will tell you that there are a lot of patients who women, like we take the brunt of a lot of things and we just often think that it must just be us and I just can't get pregnant and I'm the reason we're having miscarriages. And we never even consider that it really does take two to tango. So I typically recommend that the semen analysis is done earlier in the evaluation of infertility so that you're not stuck thinking, gosh, you know what, I've waited 6 months, wasted 6 months, and then now I feel like we're starting over. And then if you do find something that supports or explains male factor infertility, then you're kind of starting that journey. And so I think an important thing is to test early. I know sometimes these tests can be quite expensive and sometimes cost prohibitive, but you'd be surprised. There are lots of insurances that are now covering a good portion, up to 80% of fertility evaluation, management, and treatment. And so don't just presume like, oh gosh, it's going to be thousands of dollars. I can't afford it. But definitely like check with your insurance. Like again, like Margaret said, let's advocate for yourself. Check with your insurance and see what is and what isn't covered. And definitely include that semen analysis earlier on. And if you do find that, okay, gosh, there's some abnormalities in the semen analysis, I recommend finding a good reproductive urologist. All OBGYNs and all REIs and all urologists are not created equal, meaning that certain folks have their own specialties and they like certain things. I like infertility and certain urologists like that as well. And so I would seek out a urologist that focuses on reproduction and reproductive success. And usually you can find that just on different blogs or on their website. They'll mention like their clinical interests. And I would go to that person and just kind of make sure that you are one, attentive, you're listening, and you're kind of trying to evaluate or get to the underlying cause of the semen analysis abnormality. And that could be various things. It could be unexplained. It could be unexplained just like in females, but it could also be a circumstance where there's been like trauma to the testes early in life, or some kind of early childhood infection, or it could be lifestyle factors like we've mentioned a lot in this webinar, but it could also be things that are, undiagnosed. It could be a genetic condition. So I think a semen analysis sometimes for males can serve as almost like a vital sign, almost like your blood pressure. If the semen analysis is abnormal, that is letting us know that there's something going on, either whether it's hormonal or otherwise, and it needs to be evaluated. And then once you get the semen analysis, I see this a lot, Margaret, folks get the semen analysis, and it can be really difficult for guys to come to terms with the fact that it might be an abnormality with the semen analysis. And so it becomes quiet like crickets. And I think for us women, it's important that we support our spouses or our partners in this journey, and make sure you don't allow this to kind of drive a wedge between you guys. Like, this is something that should be talked about and should be discussed, and devise a plan. And often, sometimes it requires some counseling and therapy too, just to make sure that you guys just don't sit in the valley of indecisiveness, which is what I see a lot. I see women year after year, and we know that there's an abnormal semen analysis, but nothing happens after that, because either they're not advocating for themselves and their reproductive success, or the partner is just not willing to do any further research. But again, you can't correct what you don't know, and what you're not willing to challenge or change.
Yeah. And I know if your partner or you has apprehension about going in person for a semen analysis, there are some really great companies out there that offer at-home semen analysis. So I encourage you to Google and educate yourself on your options. And then additionally, if you're just looking to learn more about male fertility, we do have an excellent resource that we have on our website, a book we wrote called A Guide to Male Fertility. We partnered with our colleague, Dr. Andrew Sun, who is a urologist who specializes in male fertility, like Dr. Gleaton suggested looking for. And it's just an overview of male fertility, explains a lot. And also, I think one of the things we hope is that it helps you realize if you're facing male factor infertility, you're definitely not alone, and there are things you can do.
Absolutely. I think, Margaret, a lot of folks don't realize like up to 30 to 40% of the time it's a male factor, right? So it's very common, more common than we think. So definitely evaluate and treat. So
how often should you be having sex while trying to conceive?
depends on who you ask. If you ask a male or female or woman or man, so no. But in general, if you ask ACOG would tell you, that's the American College of OBGYNs, that trying to conceive, that journey should consist of having intercourse at least twice a week. And if you're having intercourse at least twice a week for 6 months or a year, depending upon your age, then that is sufficient without doing any other testing or any other monitoring. That is sufficient, because we know that sperm can last or can live in the reproductive organs for up to 5 days. And so that should be sufficient to conceive.
Great, thank you. Is there a best time of day to take a prenatal?
Not that I'm aware of. So I don't know. I think the best time of day is when you can remember to take it.
Yes, and most likely not on an empty stomach, right?
Yes.
Because that can make some people feel.
Yeah.
Suggestions for finding the best OBGYN that will listen.
Yeah, so this can be difficult, and I am not going to go on the soapbox, but I will tell you that the way American medicine is set up in our country is that most OBGYNs maintain a schedule where they have to adhere to 10-minute appointments. And that's very frustrating for us as providers, as well as for patients, because patients often leave feeling unheard, feeling not honored in their journey, and feeling like they're just a number. And so I think the important thing in terms of when you're searching for an OBGYN is to seek out someone, whether it be through patient reviews or friends and family, or someone who's gone through their own reproductive journey, and ask them like, hey, who did you go to? And how did you feel? And did you feel heard? And what were the response times? And, if they would just recommend that person. I think word of mouth is paramount, because again, online reviews are helpful, but there are lots of motives behind those online reviews, but I think if you can talk to a patient that's actually had care from that provider and they're willing to give their stamp of approval, then I think that's a really strong indication that that doctor is probably going to be one that will listen. And then if it doesn't work out, right? Because it's kind of like speed dating, and if it doesn't work out, don't be afraid. Like Margaret said, advocate for yourself. Find someone else. It's not permanent. You're not married. You can divorce your OBGYN and it's okay. And I think you have to understand that, for us, we love delivering babies in the delivery room. It's one of my most rewarding times. However, in 2 or 3 years, I'm not going to remember, but you're going to remember this journey and experience forever. So do not suffer with the OBGYN where you have no rapport, with whom you have no rapport, just for the sake of saving face or not being rude or not being judged if you leave.
Yeah, you have to think about yourself first. And I believe wholeheartedly with asking for recommendations from friends and family if there's someone you can ask.
Yeah.
What does a really high AMH indicate, like a 14?
So I feel like we've talked a lot about PCOS, polycystic ovary syndrome, but PCOS is one of those conditions where you have high testosterone levels and you have a propensity sometimes to have high estrogen levels too. And that combination can interfere with the body's ability to cause the ovaries to ovulate. So then you have lots of little immature follicles in the ovary itself. And those immature follicles, they release a hormone called AMH, or anti-Mullerian hormone. And because you have more than what you should have, because it's usually either about 12 follicles on each ovary or one or each ovary, because of that, the AMH levels are really high. And so often, if I would see in the office, I'm seeing a patient and I saw an AMH of 14, I'm going to really dig deep to see if they have other clinical factors like extra hair growth, acne, or any other symptoms that would suggest they might have polycystic ovary syndrome. And I'm going to send them for an ultrasound to take a look at their ovaries. I'm sure there are other causes too, but I think this is the main one we typically look for.
Great. Another endo question. Can endo thickness be too thick for implantation? If so, would a FET, frozen embryo transfer, be canceled?
Yeah, so just for folks who might not know, when she's talking about, or whoever submitted this question, when they're saying endo, they're talking about the endometrial lining. So the endometrial lining is the lining of the uterus that sheds every month when you have a cycle. And that's a good thing because you want that to shed. And typically we want that lining to be no thicker than 14 millimeters, sometimes 15 millimeters. And then after a period, we expect it to go down to about 6 to 8 millimeters, showing that the entire lining did shed and you had a successful period. However, when you're trying to conceive, you do want a significant thickness to that endometrium because that's what's going to support a thriving pregnancy, because the pregnancy has to burrow into that endometrial lining and into the uterine wall. And so at the end of the day, I think it's difficult to say a uniform number in terms of what's too thick. But I would probably say anything over, and this is just me, so don't take this to the bank, but I would think in looking at an endometrial lining, if it's much greater than 20 or 25 millimeters, I think that's probably thicker than what most REI docs would want. But again, I would kind of run this by your REI doc, only because different clinics have different protocols based on their experience, based on where they train, and based on what their preferences are.
Thank you. If sperm motility and count is the problem, what is the best treatment for this? So another question around male fertility.
Yeah, so it's going to depend on what the underlying cause of the sperm motility is. And so that could be various things, but I think digging for an underlying cause is what I would recommend, because if it's low testosterone, then there are some treatment options for that. A lot of us don't know that Clomid can also be used for testosterone enhancement and increasing those levels. But please, just a side note, do not let your partner take testosterone if they have low testosterone. So it seems like it makes sense, but it's a misnomer, because if you take testosterone and you have low testosterone, that actually serves as a feedback and tells your brain to cause your testicles to make even less testosterone. So do not allow your partners to take testosterone if you have low T. But so various other things, whatever it might be, causing the sperm motility to be abnormal or off, then I would try to correct that. And often, as Margaret alluded to earlier, it's unexplained, right? So you don't really know, but you can still work with a reproductive urologist to talk about what factors might help. And I've seen patients that have unexplained male factor infertility, and they radically changed like lifestyle things, and they have seen quite an improvement without any medications at all. Like acupuncture, holistic things also help. So just kind of keeping an open mind, knowing that this is not the end of the journey, and knowing that this is not an absolute that you can't conceive.
Yeah, that's counterintuitive. The taking testosterone may not actually be the solution if you have low testosterone. So I think
Yeah,
it goes back to your earlier recommendation that if you think male fertility is a factor, that you should seek out a urologist that specializes in reproductive health and male fertility.
absolutely.
So that was our last question. Does anyone have questions? Feel free to, we will take a few questions. If you want to drop it in the Q&A box for privacy, or feel free to drop it in the chat for all to see. Just wait a second in case anyone pops anything in. Also, thank you everyone for attending. We really appreciate you being here today. We love hearing from you. We love answering your questions. And as a thank you for joining today, you can use the code webinar on natalist.com to get 25% off a one-time purchase. All right, I don't see any questions coming through, but thank you again, everyone, for joining. I think this was really helpful. Dr. Gleaton, of course, is a wealth of knowledge. I always love when we get to carve out time to ask questions. Oh, I do see one. Oh, thank you. Thank you all for joining. So thank you. And I encourage you to go to natalist.com. We do have a blog that has an abundance of educational content. A large amount of it is written by Dr. Gleaton. So all of these topics and more are on our website. Dive in. And if you ever have questions or things that you are curious about, feel free to reach out to us at the contact email on our website. We do monitor that and we respond. And so we'd love to help. And then another question, can you share all the links that were shared in the chat today? Yes, absolutely. We will pull together an email, send it to all of the attendees that has the coupon code and all of the really helpful links that Addison shared for us. Thank you, everyone. And thank you again, Dr. Gleaton.
Thank you. Happy to be here.
Bye, everyone. Have a great day.